Okay, so apologies for the delay here, everyone, a little bit this evening, but good evening and welcome to tonight's pep talk, which is medical procedures and blood clots, what you need to know. We also would like to remind everyone that tonight's pep talk is for educational purposes only. We are not here to give medical advice. Everyone's situation is unique, and we encourage you to speak with your healthcare provider. With that, I would like to welcome my PEP partner, Todd Robertson, and our clinical guest, Dr. Jacob Cogan, who many of you may know already. Dr. Cogan, also known as Jacob, we're very informal here, is a hematologist in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. Dr. Cogan received his Doctor of Medicine from SUNY Downstate Medical Center. He completed his residency in internal medicine at Columbia University in New York, and he also completed his clinical fellowship in the Division of Hematology and Oncology at Columbia University. Dr. Cogan is also our clinical advisor to the National Blood Clot Alliance podcast, Taking a Breath. Jacob, thank you so much for joining us again tonight. You are a fan favorite, and we are very happy to have you back this evening.
Happy to be here as always. Good to see you.
Thank you. So before we turn it over to our discussion, I'm going to turn it over to Todd, actually, because I believe we have some poll questions.
Thank you, Leslie. And yeah, thanks, Jacob, for being here. It's always a good conversation with you. Here are some real quick poll questions, folks. Number one, have you ever experienced a blood clot after a medical procedure? Yes, no. Did your doctor talk with you about your blood clot risk prior to your procedure? Yes, no. If you could answer those. We only have 2 questions.
We only have 2, but they're very important questions.
Yes, they are. So if you guys could answer those real quick, we'll get into our conversation with Jacob.
I always wish I could answer them, but lots of people coming in. Oh my goodness, we have 178 people already. Wowza.
Get those results. We'll read those to you, folks. Yeah, a lot of people. We knew this was going to be a big one, Leslie. Here's the answers and the results. Have you ever experienced a blood clot after a medical procedure? 32% said yes, 62% said no, and not applicable 6%. Did your doctor talk with you about your blood clot risk prior to your procedure? 29% said yes, 41% said no, 29% not available. And that's not surprising because we hear a lot about that, don't we, Leslie, when it comes to communication?
Absolutely. Absolutely, we do. So 32% experienced a blood clot after a medical procedure. Jacob, is that high, really high? It seems very high to me. Almost a third of our participants this evening.
You know, we have a sample of people who maybe we're sort of selecting for people because they have a lot of people in the audience have had blood clots. It seems a little high, but we know that surgical and medical procedures are one of the highest risk periods for blood clots afterwards. So in some regards, I'm not surprised.
All right. Well, we obviously have a lot of work to do, and we're going to start with it this evening. Okay. So Todd and I thought that we would break tonight's conversation into 2 parts. The first part is protecting oneself from getting a blood clot after medical procedure. And then the second part is going to be focused on having a medical procedure when you are on an anticoagulant. So let's tackle the first part. It's, as you were saying, hospitalization plays a key role here. So it's estimated that almost half, if the CDC is correct, of all blood clots occur within 3 months of a hospital stay or surgery. According to CDC, also major surgery, particularly of the pelvis, abdomen, hip, or knee, are particularly susceptible to blood clots. So first question is, why is it that? We have a bunch of questions rolled up into one. So we'll start with why is that? And then let's talk about how we can protect ourselves before surgery and afterward for that 90-day period. We do have a risk checklist tonight that we're going to be sharing, and we thought maybe you could walk us through how that works. And I know it's clinical, but it's pretty easy, I think, for people to comprehend, and you could assist with that effort as well to walk through that. So let's start with the easy one first, which is why is that? And then we'll go from there.
Yeah, so I think when you have surgery, someone cuts into you or does a procedure in some way, your body then wants to heal. And a lot of us here who are dealing with a history of blood clots have some reason that our bodies maybe overreact a little bit. They skew too far in the wound healing process to the point of potentially forming a blood clot. And it can be hard without a history of blood clots to always predict who that's going to be a risk for. But I think the general rule is the bigger the surgery, the bigger the inflammation in your body subsequently, and the need of the body to heal. And thus, for some people, the higher likelihood of developing a blood clot.
And so those surgery, pelvis, abdomen, hip, or knee, are the major surgeries that lend themselves to be more susceptible than others, is what you're saying.
Yeah, any surgery where you're under anesthesia and it goes on for an hour or more can be pretty high risk. But those areas in particular, the lower extremity, the hip and knee, a lot of people are going to be immobilized after. And so that can be a particularly big reason that blood clots would form in the legs, also because that's where the surgery is happening. And then in the abdominal pelvic area, that area, there's just a lot of inflammation that can be triggered as a result, and then a propensity to form blood clots after.
Okay. And then, the 90 days, that seems like a really long time. So why is it extended for that long?
Yeah, it's hard to say. I mean, I think most of the blood clots that are going to be related to a surgery will happen within the first month, but it's not impossible that that risk could extend a few more months, and that would be related to the body's sort of protracted healing process. But I think I would imagine most happen within the first month.
Within the first month, but we should be aware then that it could go up for
Mm-hmm.
30 days. Would you include pregnancy and delivering a baby, whether vaginal or C-section, to be included as a high risk as well? And
Oh, yeah. I mean, that's probably its own topic, but the pregnancy in general, and especially the postpartum period, is maybe the highest risk for blood clots of any situation. And that again is due to a lot of blood loss in the delivery, often the body really wanting to heal. And that risk for sure can go on for up to 3 months. So that's a period we really are wanting to identify people who have a history or are at high risk of blood clots so that we can prevent it.
mhm. And is it elevated in the event of a C-section?
I would say so, yeah, because again, that's a surgery on top of, childbirth, which by itself is high risk.
Yeah, okay. We have a risk checklist that we wanted to discuss with everybody tonight. I'm hoping the NBCA team can bring this up. But it's called the Caprini score. And we thought this might be actually a great thing for people to have before they go in to have surgery, and have this conversation with their doctor. And I'm going to ask, gee, how can we actually bring that up? Is that, sorry, something that the NBCA team can put on the screen, or maybe Jacob, you could bring it up. Is that possible?
I could
You really want to
try.
share it with everybody.
Do it either way. It's in the chat, so you let us know.
Okay, thank you. Let's see if that works. Does this work? Can you see it?
Got it.
Yeah.
Okay, great. So walk us through what this is.
So there's a lot of different scoring systems, and I think the idea is you take a patient, you take their type of surgery, and you try to estimate what their personal risk for getting a blood clot after the surgery would be. So at the top, we have some of the most important factors. So age, we know that increasing age increases the risk of blood clots. Gender, male gender tends to be higher risk. Type of surgery, so this is also really important, where we're looking at the specific surgery the patient is having, because as we just were discussing, there's certain surgeries that are particularly high risk: orthopedic surgery, surgeries with anesthesia more than 1 hour, abdominal, pelvic. Those are going to be really high risk, and we want to pay attention to those patients. Keep scrolling down. Yeah, so, and then we're looking at some comorbidities or other sort of medical issues that might be important. And for people who have had any of these things, so another surgery recently, if they've had infections or if they've been immobilized, I actually personally don't use this score a lot, but I think we're going through a lot of different elements that go into this particular score that make us want to pay more attention to a patient's personal blood clotting risk. Definitely if they have a history of blood clots or a family history of blood clots, if you have one of these blood clotting conditions diagnosed. So again, a lot of aspects of each person's individual history that might raise our concern that we need to take precautions for a patient post-operatively.
Mm-hmm. Okay. So you basically add these things up. I mean, you talked a lot about inflammation. So BMI, for instance, does lend itself for increased levels of inflammation in the body. So you actually get a score for that. Okay. So you go through this checklist and people can kind of use this as a guide, if you will, if they're planning to go in for some type of surgery and have this conversation with their clinician.
Yep.
Okay.
And, I think it's important, of course, to say that it's our job, providers, to identify patients who are at high risk. But I'm sure, as a lot of the audience knows, maybe we should be doing our job better in some regards. And so, it's always great when patients take it on themselves. You shouldn't have to, ideally, but if patients can advocate for themselves, say, I have a personal history or I have a family history of some of those things that you might have seen up there, and bring it up to your surgeon, bring it up to your hematologist if you have one, even bring it up to your primary care doctor, because I think this is one of those things that can fall through the cracks. Again, for us as hematologists, we're very focused on this, but we don't necessarily evaluate every patient before they have surgery. And so you just could imagine that someone going in for an urgent gallbladder removal or appendix removal, maybe it doesn't get discussed in the ER what's going to happen to you after you leave the hospital. So it's always good to be bringing up, I have a history, or someone in my family, do I need to be worried about blood clots? That's probably a good question for all patients to be asking, no matter what your history around the time of a surgery.
Yeah. I mean, I think part of the problem is not everybody has access to Dr. Jacob Cogan. So, we want to make sure that people have the tools available that they can go to the hospital or meet with their doctors and say, hey, I'm going to have a procedure or surgery. These are risk factors. How do I protect myself? And not just during the surgery, but 90 days, up to 90 days post. Todd, turn it over to you.
Well, thinking about all that, so it kind of leads me to one of the questions that needs to be asked, because we get this a lot in the support group. But Jacob, let's talk about injections. And I'm talking about spinal, knee, even Botox and fillers, cortisone injections for pain. From the very serious to the perhaps not so serious, what are the risks of clotting when it comes to injections? Anything we should know about?
So, again, it's a little bit variable based on the location of what's being done. Anything with the spinal cord is always going to be a bit higher risk. If we're talking about Botox injections, if we're talking about kind of a joint cortisone injection, generally that's not going to be such a big concern. Not that it shouldn't be a discussion with one of your providers, but we're generally worried more about patients that are getting a surgery with general anesthesia, meaning they're put under Whereas with some of those injections, you might just get local anesthesia, and that doesn't quite increase the risk, especially if you're going to be up and moving and back to your normal self kind of after the procedure.
Sure.
Well-
And there's actually another procedure we'll talk about later, and that kind of segues into the being your own self-advocate as well. But we'll talk about that later. But thanks for that, Leslie.
Why do the spinal injections lend themselves to be a greater risk than the other injections? I mean, obviously the spine, but like, what is it about that?
I think it's partly, I talk about inflammation, which is a difficult thing to kind of quantify. It's more of a clinical issue that we kind of have senses of. But I think the spinal cord is an area where you really don't want any injury. And the body, I think, reacts more significantly to surgery in the central nervous system, in the spinal cord. And that's why we can sometimes see blood clots after. And the second aspect of this, which I think is an important point, is that surgeons, understandably, are always going to be worried about bleeding. They don't want patients to bleed after surgery because that can cause its own complications, which have to be taken into account. But we in hematology like to say that if there's bleeding after the surgery, then the surgeons might say that's their fault. But if a blood clot happens, then it's an act of God. But obviously, we know that that's not the
Right.
case. Blood clots are a medically preventable issue as well. And so I think part of why I've mentioned spinal procedures is that sometimes we find that the surgeons are so concerned about preventing bleeding that they might wait too long and not provide enough protection against blood clots. And that's often when we see them, is when the concern about bleeding might be so much that you're not focused enough on blood clots.
So you've mentioned anesthesia, I think twice, and I noticed anesthesia was referenced on the Caprini checklist as well. Is there anything related to anesthesia that lends itself to increasing the risk of blood clots, or is it just that anesthesia is used for longer durated surgeries?
Yeah, I think it's more about that you're talking probably about a more invasive, a longer procedure. And it's probably sort of a proxy for, okay, this is going to be a bigger procedure with a bigger recovery and more sort of tissue damage through the surgery that can lead to the inflammation and the shift toward wound healing and maybe blood clotting in some people that I've mentioned.
Okay. And you also referenced that men are slightly higher risk than women. Why is that?
Yeah, it's a good question. I don't know, except to say that that's what our data generally tells us, that as people get older, blood clots happen, actually really across any age, blood clots really happen more in men. Women can be in certain situations, such as pregnancy, using hormones, things like that, where there can be particularly high risk. But in general, male patients have a higher risk of blood clots.
That's interesting. I wonder what the if it's comorbidities or height or who knows, but
Could be.
that's very interesting. Okay. Yeah, and we have a lot of patients who are inquiring about injections and do they need to, protect themselves in any way, but it sounds like it's really the longer duration procedures that are the issue.
But I think, if I could, the one thing that I'd want people to take away is that really it's just good to have someone you can go to when you're having any kind of procedure. I mean, I think it's worth bringing up to the surgeon, but it might also be good to bring up with someone who knows you. So if you have a primary care provider or you have a hematologist, you can let them know you're having the procedure. Do I need to be worried about blood clots? Or do I need to, if I'm on a blood thinner already, what do I need to do with my blood thinner around that time? And what should be done after to prevent blood clots?
Real quick, I've noticed that a lot of patients just kind of go by what their surgeon may say. And some of the guidance that we kind of put out there is it's a really good idea to have the hematologist and the surgeon have a powwow and come up with a game plan together, right? I mean, really, I think the hematologist should be brought into this to make
We
some
do
of
that
this.
all the time.
all
I
the time.
wish I got called more,
Sure.
honestly.
Mhm.
Yeah.
I bet the patients do too. Okay, so let's switch gears here a little bit. And so for those of us who are on an anticoagulant, we've already had a blood clot, which is probably most of the folks on here tonight. we now need a procedure. How do we manage this? What is the pre-procedure conversation to have with the medical team, which we've kind of touched upon, but, kind of walk us through that. And then, procedures take many different forms. And so let's discuss procedures versus surgery necessarily. And we'll start with maybe
Yeah.
some things that are more benign, like dental. And,
Yeah.
does one need to come off of their anticoagulant? Because that's the scary part, for those of us that have had a blood clot or are on an anticoagulant. Do we have to come off?
Yeah. So it's a really important question. And it, again, really comes back to having someone that can guide you through this, because there definitely needs to be adjustment around the time of procedures with your blood thinner. And there's a lot of nuances based on what type of blood thinner it is, what type of procedure it is. Generally, we look at the procedures as how high of a bleeding risk are they? And if they're very high bleeding risk, so again, something in the central nervous system, in the spinal cord, we might hold it, the blood thinner, stop it for longer before the procedure and longer after the procedure than we would for, let's say, you're getting a mole removed or something like that. And then it also depends on the drug. So if you're taking Eliquis or Xarelto, we probably, on average, although again, it depends on the procedure, are going to hold it for 2 days before to let it get out of your system and then resume it about 24 hours after. But if you're on Coumadin, of course, Coumadin has all its own stuff that goes with it. And for some procedures, we might just have you wait to, or you stop taking it 5 days before and we let your system normalize and then you start it again after. Or we might have you stop it and take a different blood thinner like Lovenox for a few days. So again, I mean, you're hearing all that I'm talking about. It's just even more reason that you should not feel like it's on you to know what you're supposed to do before this stuff. Your provider and your surgeon really should be helping you through this and talking to each other. I mean, I really like it when I get put in touch with the provider, the person who's doing the surgery, so that I can make a plan with them based on what I know about the patient.
Yeah, it's very confusing for us because we get conflicting information from different doctors, even if they're part of your own team. Can you just walk through for everybody, because we kind of use these terms because we're used to using these terms, but the difference between, like, what is Coumadin versus a DOAC versus warfarin?
Yeah, so probably I'm guessing, I might be wrong, the blood thinners that most people are on or familiar with are drugs like Eliquis or Xarelto. Those are newer drugs that have been developed that sort of have a very specific way that they act against the body's clotting system that is very predictable.
Mm.
And basically those sorts of drugs, Eliquis, Xarelto, work the same way and are often handled the same way around the time of procedures. There's also Coumadin, which is the same as warfarin, which is our probably longest blood thinner that we've had other than heparin. And it's what most patients were on until we got these newer DOAC agents like Eliquis or Xarelto. Coumadin acts a little bit less specifically. It acts on a few different things, and it needs to be controlled in a specific range with blood tests that you check, the INR, whereas the DOACs, Eliquis, and Xarelto don't need that. And there's a lot that goes into Coumadin that requires even more delicate handling around the time of procedures. And then, we haven't talked about Lovenox, we haven't talked about Arixtra, we haven't talked about Pradaxa.
Yeah.
So, there's pills, there's injections, and they work different ways and they need to be handled different ways.
What about reversal?
Yeah. So that's its own topic. I mean, reversal, I think of more of if there's bleeding. Is that what you're asking about
Yeah.
too?
Yeah.
Yeah. So, I mean, this is its own can of worms. We hope no one ever needs an urgent surgery, but you could. And if you did, I think we talked about this in probably all our prior sessions that I've been a part of. Another thing I would wish for all the patients here is to have a medic alert bracelet saying that you're on a blood thinner so that it can be and what the blood thinner is, so that it can be identified and dealt with the right way. There are reversal agents for the majority of blood thinners, meaning you can give a drug that will sort of get rid of the effect of the blood thinner in your system. And that's important if you need an emergency surgery. We don't want to be doing surgery on people who have a blood thinner in their system. And that's why we're talking about around surgeries, how to prepare so that the drug is out of your system for the procedure, if that's necessary. I see in the chat, and it's true, some people, or some procedures, you don't need to hold the blood thinner. It's not a high bleeding risk procedure. You can just stay on your blood thinner and it should be fine. And that is the case for some procedures. But for most, that's not the case. And we don't want to, we don't need to use reversal for routine planned surgery. But if it was an emergency, we might.
Can you update us? Okay, tell me about Andexxa. Okay, that's the reversal agent. Okay.
Yeah.
Because people hear that, oh, well, there's a reversal for Xarelto and for Eliquis, but my hospital doesn't have it, and they say it's too expensive to carry. So, I mean, some hospitals have it, correct? And some hospitals don't. It would be really nice if everybody just had the thing, right? You make people feel better.
I have to, so we still have some things to figure out about that specific drug. So Andexxa is the reversal drug for Eliquis and Xarelto. And it is being studied and it's out there. But I don't think that it's quite ready for prime time everywhere yet. Coumadin, it's a difficult drug to take, but it's easy to reverse. We have a lot of experience with that, and we know exactly how that works, and we can do that safely. These Andexxa for Eliquis and Xarelto, we still have a lot to figure out. It works, but there does seem to be a risk of blood clots after getting it. And that may have something to do with the drug. It may have something to do with people not getting started on their blood thinner again as soon as they need to be, because your blood clotting risk doesn't go away after having bleeding. But I would say that, there's a couple different things we can do. There's PCC, Kcentra, other drugs for people who are bleeding who are on those drugs, but I don't think we're quite at the point yet where my hospital has it and we have protocols around when we use it, but it's not, for Pradaxa, there's Praxbind, which works great, and we want everyone to get that when there's bleeding on that drug. And Andexxa, it's not quite there.
I found out that it's at my hospital, the one that I go to for just about everything, but that it's hardly ever been used, which is good news, right? But I mean, they have it, but a lot of places don't. I mean, that's really interesting. I'm glad I asked you about that, because I didn't even think about or know about the possible blood clot issue and whether that's because of the drug or the anticoagulation misfire or whatever. But that's
We're a
good
little
information.
worried about that in the hematology community based on the most recent data from that study. So I'm not saying it can't be used. I think there are situations where it should be used, but it's not quite ready for everyone to be having it and all the time yet.
Okay, great. Thank you.
So for a lot of folks that wrote in and said, I'm having a dental procedure, it sounds like for the most part, they don't have to come off of their anticoagulant.
I think a lot of dental procedures you don't, certainly not a cleaning. If you're having teeth extracted, if you're having a crown, there's nuances there also based on what kind of blood thinner you're on. So I wouldn't assume that for a routine dental procedure, you can just stay on it. I would ask at least your dentist, if not also your hematologist or primary care doctor, because dental procedures, depending how invasive they're on, there can be a lot of bleeding from those. So, and I also think this brings up that understandably, people who are on blood thinners are going to be nervous to stop their blood thinner because you don't want to get another blood clot.
Right.
And there are some patients where I never want them to be off it, almost under no circumstances. But a lot of patients, we feel okay about interrupting it around the time of procedures because the day-to-day risk is not so high and the risk of bleeding from the procedure may outweigh that. So I would still say, it's hard to give a blanket rule. I wish I could, but I would say it's correct that a lot of dental procedures, you don't need to stop it, but I would still ask.
Well, and it's really bizarre because you could have two patients on Xarelto and similar clots, similar history.
Hmm.
One could get an extraction and not have to come off the anticoagulant and have no problems. The other one
Hmm.
bleeding all over the place. So I
Hmm.
think it's really patient specific too on this
Oh
bleeding
yeah.
thing, right? Because I've never had to come off for an extraction. I didn't have to come off for a root canal.
Yep. No,
So it's really
there's no
bizarre.
question. Yeah.
Yeah.
Yeah, we actually have somebody in the group who asked, can you get a blood clot from a dental, I don't even know what this is, an apioectomy? Uh,
Yeah. Usually dental procedures, we're not worried about clotting because those don't tend to be long and extensive enough. Usually it's local anesthetic. Usually they're fairly short procedures. So those I'm not thinking as much about being a risk of blood clotting. I'd be more worried about bleeding.
So if you do have to come off for some reason, do you wait the same amount of time that you would for surgery or procedure, or can you come back onto your anticoagulant sooner?
Usually for routine procedures, dental, actually colonoscopy is a good example. But so for most procedures, we have people stop something like Eliquis or Xarelto 2 days before and then resume 24 hours after, but with the caveat that you have to see what happens in your procedure. So if you have a routine colonoscopy, they don't do anything, you can go back on it within 24 hours. But if they take out a bunch of polyps, then we might be worried a little more about bleeding,
Yeah.
and then we might want you to wait 48 hours before you restart it. So again, really important to be communicating with the person who does the procedure before and after, and also with your primary provider to make sure the decisions are being made correctly.
Okay, we're actually going to talk about colonoscopy because that's another major question that that the patients have, and we're gonna ask Todd to actually share his story on that. But before we get to that, let's also talk about biopsies. So
Yeah.
again, how far in advance does one typically come off the anticoagulant? And again, does it matter which anticoagulant you're on? Is there bridging involved? And then again, how long afterward can one resume their anticoagulant? And what if a patient has multiple risk factors or the patient has APS?
Yeah.
How do you handle
Mhm.
this?
Yeah, so the type of biopsy matters. If it's a skin biopsy, you might not even have to stop what you're on. If it's a kidney biopsy, then we're really worried about bleeding and we need to have you off of it for a few days before and a few days after. Um, you mentioned bridging, which is great because it sort of it helps with the distinction between Coumadin and some of these newer drugs. Coumadin, we often would need bridging um, because to get back on Coumadin safely, you often need to have bridging done. It's just the way the different blood thinners work. There needs to be some overlap. The newer DOACs, Eliquis, Xarelto, you don't need bridging. The drug doesn't really need to build up in your system. You give it to the patient and it's at the level it needs to be at. So there doesn't need to be bridging. And I think just to back up, bridging would refer to use of a different blood thinner in the time where you are holding the primary blood thinner. But, also the patient's blood clotting risk makes a difference. So let's say I have somebody who has APS, who's a really high clotting risk, and they need a kidney biopsy or they need a liver biopsy. So I'm going to want them to hold, if they're on Coumadin, several days before the procedure, maybe 5 to get it out of their system. But once the drug starts to get out of their system by day 3, by day 2 before the procedure, I'm going to want them on something to bridge the gap. So Lovenox shots for a few days, maybe at a low dose. So there's still prevention against clotting, but not so much of the drug in the system that the procedure is going to cause bleeding. So again, a lot of nuance to this stuff.
Um, Same thing with endoscopy.
Yeah, again, it's sort of what exactly is the procedure? Is it a colonoscopy? Is it through the mouth, what we call an EGD? Are they going to be doing biopsies? Are they going to be removing polyps? Or are they just taking a look at something? If they're just taking a look at something, it's possible you don't even need to stop it, or you can have a very brief hold. But if they're going to be doing an intervention, you need it a little longer.
Okay. All right. Thank you. I mean, it's really quite nuanced and varies by procedure, varies by person, risk factors, et cetera. So this conversation with the clinical team is so very, very important. Todd?
Yeah, well, when you talk about colonoscopy, it's like that sends me back to 2017 because that's when I ended up with my pulmonary embolism, and it's the only I've had a lot of DVTs, but I've only had the one PE. And I do want to make something clear as I go into this. I think colonoscopies are extremely important. And I can say that it literally saves my butt every time. And right now I'm getting one. I was getting one every 3 years, and now I'm getting one every 5 because they're always finding precancerous polyps and having to cut them out. And then, we can get some more opinions on the bridging thing here. I'd like to get your opinion on this because here I am, homozygous factor V Leiden. At the time, I already had a history of 5 blood clots. And we were talking about being empowered to be your own advocate and ask questions and get everybody on the same page. I really dropped the ball on myself. I actually take part of the blame for this because I should have been a better advocate and caught that red flag, but I was stopped for 72 hours for that first colonoscopy. And yeah, they cut out a couple of polyps. The surgeon, later said you hardly bled at all. But yet those doctors knew that I was homozygous factor V Leiden, and they knew that I'd already had 5 blood clots. There was absolutely no reason to stop me for 3 full days. And 4 or 5 days later is when I got the pulmonary embolism. So now when I get a colonoscopy, I am off. Now I'm on Eliquis, not Xarelto, but I'm off for 24 hours. That's it. And it's the risk. We got to weigh out that risk versus benefit thing. And I have a problem with blood clotting. I do not have a problem with bleeding at this point, knock on wood. But what would you have done? I mean, when you think about it, there's so much to think about, but the hematologist and whoever was doing the colonoscopy really needed to have a conversation. And I don't think they had that conversation.
No, it's an amazing, I mean, I'm very sorry that happened to you. It's an amazingly educational anecdote because, it sounds like we're not talking about that big a difference, 48 hours after, 72 hours after, and you can maybe imagine how this, if the surgeon didn't really appreciate your condition, they might say, well, I might want the extra day to reduce the risk of bleeding. But you have homozygous factor V Leiden and you've had blood clots before, that's a patient where I want as minimal interruption as possible. And I would try to, convey this to the person doing the procedure. I'd be okay taking some risk of bleeding, because you can deal with bleeding and we can treat blood clots, but in your case, the risk of clotting with that particular procedure, I think really outweighs the risk of bleeding. So I think, the 24-hour hold before is very appropriate. Maybe you take a little more risk of bleeding because there's more drug in your system than if you held it for 48 hours. But I think that's a risk worth taking in your case. And then afterwards, I would push to have you back on something within 24 hours, and maybe not your full dose of Eliquis, but a half dose, a shot of Lovenox. Like that's where we get involved with, okay, it doesn't have to be all or nothing. Maybe there's a little bit of something that can be given. So it's easy for me to, Tuesday night quarterback this situation, right? But it does speak to, again, the nuances here.
It does. And, I share the story a lot because that's my PE story. I've got DVT stories, but that's my PE story. So I end up sharing that information a lot and that experience. But that's why I started off with, I want everyone to know that personally, I believe colonoscopies are extremely important. It's a very smart decision to get screened. I think they've even lowered age now. I know this isn't a colonoscopy show, but I don't want people to think, oh God, I don't want to get that kind of procedure because look what happened to him. No, what happened to him was because of an error in the communication and the decision making. It wasn't the colonoscopy itself, right? That's just what I like to tell people. But I wish you would have been there, Jacob. I wouldn't have had to deal with this. But
It's easy
I mean,
for me to say in
everything you
retrospect.
said makes perfect sense. Maybe not the full dose, maybe just a, a lower maintenance dose or what to get it in my system. Maybe that would have been enough. But yeah,
Yeah,
we have to be careful with these procedures. So it's really good to team up with the doctors, make sure they're all talking.
completely agree.
But so Todd is in a really interesting case because he's high risk. For those of us that might be run of the mill clotters, is there a protocol for colonoscopies typically if you are on an anticoagulant? I know you said you would treat Todd differently, but is there a protocol for this?
I think so. I think in most places, that maybe there's a difference in if you're going to a private practice somewhere or a big academic medical center. I would say the academic centers maybe are a little more likely to have specific protocols.
Mhm.
But I think in general, you're talking about holding for 2 days before and resuming 24 hours after, just as kind of a blanket rule for colonoscopies. But
Mhm.
again, you see that based on your specific situation, you being whichever patient we're talking about, there are nuances. And, there's also, I mean, this is part of what's interesting to me about hematology is that I went through medical training and, there's lots of surgeons, there's lots of primary care providers, but it always felt like there's room from the hematology side to get a little more involved in these decisions. And it just seems like there's not enough of the blood clot prevention aspect of things being attended to.
Mhm.
Well, we as patients would absolutely agree with that statement, which is why we're trying to get the word out and educate folks.
Well, yeah, and it's a positive thing. I mean, what happened to me was a bad thing, but it also made me empowered to be a better self-advocate
Hmm.
where I can communicate with doctors now with ease. Where before I wasn't able to do that. Now I've kind of got it
Right,
down. So trying
right.
to help patients find that, midline to where they can be better communicators with their doctors too. And the doctors got to be better communicators for sure, like you said.
Yeah,
What about women in hysterectomies?
yeah. I would say that's, because we're talking about a abdominal pelvic surgery. Um, and I would say that's a very high risk situation. And, I don't know that every woman who gets a hysterectomy needs to be on a blood thinner afterwards. If you're young and you don't have a history of blood clots, you don't have a family history, you go through one of those checklists we looked at before. Again, you shouldn't have to do this. Ideally, your provider goes through, you don't have risk factors. Most likely, you're not going to have a blood clot. Maybe 1 in 100, 200 might. But in general, I wouldn't say you need to be too worried. But if you do have a family history, you haven't had a blood clot, but you have a family history of blood clots, then maybe the person doing the procedure is going to say, I do want you to take something for a few weeks after the procedure,
Mhm.
because if you get a higher score on that Caprini score we were talking about, then we might worry a little more about you and we might want to give you something to prevent that after the procedure. And now that we have Eliquis and Xarelto, it's much easier for patients. You don't have to inject yourself. You don't have to go through starting Coumadin. You can take a pill once or twice a day for a few weeks, and that makes it a little easier, other than the expense. I really wish that was a better part of those drugs, but someday they'll be cheaper. But it is easier for patients to take those in those situations, which lowers the bar to giving treatment to prevent blood clots for patients who need it.
Yeah, all great points. Okay, I think what we're gonna do is finish up with kind of one last question slash comment, and then we have a ton of questions from people that have been sent in and also in the group right now. We'd really like to get to a lot of those. So, you touched upon clinical teams earlier.
Mhm.
Um, can you just kind of guide us through? You've got a surgeon, and by the way, when it comes to hip and knee, they love to give people aspirin. So how do we navigate that? The role of the PCP and the hematologist. So a lot of times if you haven't had a blood clot, but you could have other risk factors to get a blood clot, you probably don't have a hematologist. In which case,
Right.
like, how do we actually navigate that? Um, especially with risk factors. I had a breast biopsy a couple of years ago. And I was the navigator between my pulmonologist, the radiologist, and my PCP. I don't think that's normal.
Yeah,
That wasn't an academic,
it's a tough
center.
position for a patient to be in, to have to do all that coordination. I would say whoever you are, you should always ask the person doing the procedure. As simple as, am I at risk of blood clotting? Ideally they would flag it based on your history, but not always. So I think that's the first thing for sure. If you have a hematologist, if you have a primary care provider, you might also want to reach out to them and say, I'm getting this procedure. Do I need to be worried about blood clots? And then say, could you talk to my surgeon? Ask the surgeon, could you talk to my provider? And, so I think something everyone can do is ask the question to the person doing the procedure. The rest of it is complicated and patient specific, but, surgeons ideally care about that complication of procedures just as much as bleeding and should be able to put something in place. And, aspirin sometimes is appropriate. There's some debate about that too, honestly, if that's enough of a drug to prevent blood clots for patients at high risk. I'm not so sure. I think it is for some patients, but sometimes that might be all you need is a baby aspirin for a few weeks. So again, unfortunately, you can't rely on the surgeon, on the providers to recognize this risk, and some of it needs to be asking the question to protect yourself.
Yeah, no, great advice. Okay, Todd, I'm gonna kick it over to you with Q&A, and we got lucky so far here tonight. Jacob is on call and thankfully did not get called away.
I
So
hope not. Sure.
very happy about that.
Yeah, hey, we've got a lot of questions. I'd like to get to many of these as possible, so let me just start barreling into it. Someone is asking, can I safely have laser eye surgery to correct nearsightedness? And as a little bonus question to that, not related, but can I safely be a blood donor while I'm on anticoagulants? I get that question a lot.
Yeah, those are good questions. I would think, you can get any procedure when you're on a blood thinner. There's no procedure that can or that should be restricted to you. I would think that something like LASIK, maybe you would need some interruption, maybe not, depends. But remind me the second part of the question.
Can I safely be a blood donor while I am on
You might need, I
anticoagulants?
think you can. It might be that you have to stop the drug for some amount of time before you donate. And again, it might be a similar situation. 2 days,
Which is
you
risky.
stop it.
That's pretty risky.
You'd have to think about your personal risk and
Yeah.
how important this is to you. I think for most patients, 2-day interruption, give blood, and then go back on it should be okay. But I'm sure that's part of the screening for blood donation also.
Okay. All right, Leslie?
So there are things out there called natural blood thinners in addition to the DOACs or whatever people may be taking. So comment on that. COQ10 is an example, some vitamins. You come off your DOAC. Should you also be coming off these?
Very important to talk about those kind of supplements with a provider because some of them can be associated with a higher risk of bleeding, and you might not even know it depending on what sort of formulation it is, what's in the compound of a multivitamin, and especially if you're on a blood thinner, ideally you wouldn't be on those sorts of things unless it's really necessary if you're on a blood thinner. And then if you're not on a blood thinner, but you're taking something that could increase your bleeding risk, yeah, I would stop it around the time of a procedure for sure.
Okay, great. Todd?
I can't remember if we touched on this or not. I don't think so, but is there a critical period after a procedure in which clotting is more likely to occur?
Yeah, I would say within the first few days, and often we're seeing it after a week or 2 weeks after a procedure. That's really the time that we're the most concerned about. And that's why we want to get people on treatment as soon as possible, as is safe from a bleeding perspective after the procedure. Those first few days are really critical, especially for major surgeries.
Okay, thanks, Leslie.
Interesting. So just a few comments that I find really interesting in this group also. I had a spinal injection and 3 days later ended up with a PE. Nobody ever told me this could have caused it, but you know now not to do spinal injection. So exactly what, you were talking about the risk associated with spinal injections and blood clots.
Not that people shouldn't do them. There's lots of appropriate reasons to do them.
Yep.
And even if you're on a blood thinner, you can. But again, the importance of having a plan in place to protect yourself.
Yeah. So another factor 5 individual,
Mhm.
factor 5 positive for heterozygous, what precautions should be taken? And also, is there anything that I can do beforehand with regard to diet and exercise?
Hmm. So it depends on if you're on a blood thinner already or not, of course. But if you're not, assuming you're not, but you know you're a carrier of that, letting the person doing the procedure know, because even if you're not on a daily blood thinner, they may want you to be on something after the procedure, and they might not even know you have that unless you advocate for yourself. And then, unfortunately, I think, any kind of moving around, exercising as much as possible after surgery, obviously exercising, not so much, but whatever sort of mobility you're allowed to do is a good thing to do, because that will, if you're in bed and you're not really moving, that will increase your risk. But in terms of before the surgery and even after, in terms of prevention, it's really hard on the because you may not be able to get up and move. And that's why we have to protect you with medications or however we approach it.
Mhm. Okay.
Another question, and this comes in to the support group a lot, so would love your opinion. A lot of people are interested in acupuncture, including dry needling. But does any of that affect patients like on a DOAC, on Xarelto or Eliquis? I think they were specifically asking about Eliquis, but what about acupuncture treatments?
Yeah. I would say for most people, you probably err on the side of not of interrupting it for a few days. I mean, again, you can get acupuncture, and it may be that, I always look into what literature has been published about a particular procedure. So I don't have a lot of patients who have gotten acupuncture, or they don't tell me they're getting it. But I would look and see what's been published, what kind of bleeding risk is it. Sometimes I'm surprised and it's not so much of a bleeding risk, and then I'm less inclined to recommend stopping the blood thinner. But again, for a lot of people, interrupting for 2 days and then restarting after is not going to put you at such a high risk of blood clots, and will prevent any bleeding complications with whatever procedure you're getting, but with the caveat that I feel differently about certain patients who I know are at really high risk of blood clots, in which I might say, I'd want to avoid unnecessary procedures if possible, or if it's really necessary, have as little interruption as possible.
I'm thinking you might have a few people out there that may not want to tell you that they're going out to get a tattoo tomorrow either.
That one, people do ask me about that.
Good,
And
good.
that, often, again, I think
Whole
depends on
nother
how big
topic.
of a tattoo we're talking, but
Yeah.
you often could do that without stopping the blood thinner. But, the tattoo procedure might go better if you're not on it and there's not bleeding.
Well, and some are small and take a short duration. Others are a 9-hour sit. I've gotten a lot of tattoos since I've been on Xarelto and never had to stop. So, but I
Okay.
think it goes back to patient specific. But,
Yeah.
okay, thank you. Leslie?
Everybody's different,
Yeah.
Todd doesn't bleed that much. I cut my finger on a piece of paper and I'm off to the emergency room. Like it's it's so
Not laughing at you, laughing with you.
Thanks.
No, it's
Okay.
interesting.
Laughing with you.
I was like, why is he laughing about that? That's not funny.
It isn't.
So another question, I have May-Thurner. Is my risk higher for a procedure because of that?
Yeah, if you know you have that anatomy, that is for sure important to talk to your provider about. And May-Thurner is usually not something we know about most people. anatomy, an abnormality in how your blood vessels are in one of your legs that puts people at risk of blood clots. And often we don't find out someone has that until we have a blood clot. But if you do know you have something in your anatomy that puts you theoretically at risk for blood clots, then for sure your provider should know about that.
Okay.
Real quick, what about massages, Jacob? People want to get rub downs. When can they do that? When can they not do that?
I think that's okay. You know, I think people sometimes you may hold it depending on if we're talking about a really deep tissue intense massage. A lot of times I think you won't need to stop it, but you shouldn't, not do things like that are helpful for you because you're on a blood thinner and maybe worried about bleeding. But again, there's no question that would be wrong to ask your provider about what should I do around this kind of thing. But I think most of the time you can get a massage without stopping the blood thinner.
Another one of those risk versus benefit, but the massage feels so good, it mentally, makes you feel so much better too, that
you should.
Kind of important.
Oh yeah.
Leslie?
Reward. I had hip replacement 10 weeks ago. Am I safe from clotting?
Sorry, these comments always
I know.
are very interesting to me. They didn't find my May-Thurner until my third clot. Wow. Say that one again.
I had hip replacement 10 weeks ago. Am I safe from clotting?
I would say yes, to go more than 2 months. I can only think of one case I've seen where somebody thought that a blood clot was related to a surgery they had, almost 3 months prior. It's not impossible, but I'd say it's pretty unlikely at that point. I think that first few weeks up to a month is really the critical period.
Okay. Mr. Robert?
I feel being on a blood thinner doesn't allow me to ask this question, but I'm wondering about plastic surgery.
Yeah, again, not something that you should deny yourself if you want to do it. And I would think that most of those procedures are going to require holding the blood thinner for some amount of time, but certainly can be done, but again, very important for the person doing the procedure to know you're on a blood thinner.
Yep.
And if you're getting it and you're not on a blood thinner, to ask about your risk of blood clots after, because those are surgical procedures and you could have a clot after them. I've seen that for sure.
I think you need to be cloned because everybody wants you to be their hematologist now. And there's not enough of you to go around.
Well,
you do telehealth.
What is it? It's -4 here in Minnesota right now. So I don't think anyone's moving out here.
You're right up the road, and we're going to get buried in snow tomorrow down here in Iowa.
I'm happy to see you by video.
That's great. All right. Listen, it's 8:02. We know you're on call. Unfortunately, we can't get to everybody's questions, but as always, you've been fantastic. We want to thank you for your time this evening and helping so many of us and just being such a great advocate for the patient community. You're fantastic. And Todd, you're pretty darn good too.
Aw.
Thank you. Thank you always for having me. It's great to be here.
Oh, love you, Jacob. Yeah,
you're awesome.
You give great answers, and you do a great job of explaining to the patients, which is they want simplicity when they hear an answer, and you're really good at delivering that. So thank you so much, Jacob.
Thanks. And again, I'm happy if there's a way to answer some of these questions offline. I'm happy to do that too, because they're great questions, and I learn things too. So
yeah, we'll have to do a 2.0 because we do have so many questions, and I'd love to get to them, but we do realize that you're on call, and we appreciate the time tonight.
Absolutely.
Bye-bye. Thanks, everybody.
Have a good night, everyone.
Bye, everybody.